good morning to this morning's Meet the Experts session. It's my pleasure to introduce Dr. Tilman Esser this morning. Dr. Esser works since 2007 in the Center of Prenatal Diagnostics in Munich. He studied in Berlin. He used to work at the Women's Medicine Department at the Charité University Hospital in Berlin. Actually, he co-worked there together with Professor Rabi Chaoui, and Professor Chaoui was also the one who trained actually Dr. Tilman Esser in prenatal medicine as well.
The best guy in the unit.
Dr. Esser will give us insights in first trimester and his experience in on the Volleson Expert 22. So very happy to have you here.
Thank you very much for the kind introduction. First, I want to say I'm very grateful for having the opportunity to work together with the Volleson team from ZIP. And I want to share my experience with the new system in the first trimester with you. We've seen two major steps in the last 3 decades. First, the introduction of first trimester screening by Professor Nicolaides and co-workers. And second, a significant improvement in ultrasound technology with enhanced resolution allowing detailed anatomic evaluation, improved color and high definition power Doppler for evaluating the cardiovascular system, and enhanced volume imaging. So what do we expect from a new system? Well, high resolution, sensitive color, high quality 3D volumes combined with sufficient penetration, preferably with a transabdominal probe and preferably with one probe. Fast, sharp, and clear images without spending too much time on manipulating settings. Well, all the following, or most of the following clips and images are acquired with a transabdominal RM7C probe. Until recently, we often needed a transvaginal approach to achieve high-resolution, detailed images. With the new system, almost all structures we want to examine can be displayed with the transabdominal probe. I want to show you some clips and images, and I want to show you what is possible with the new system and what can be seen quite easily in routine first trimester ultrasound. I will not go through the whole fetus, and I will focus on some structures that has been labeled as optional in the ISWOG practice guidelines published nearly 10 years ago. So we start with a mid-sagittal plane, and this enables the assessment of many anatomic regions like the nuchal translucency, the nasal bone, maxilla, mandible, the thalamus, brainstem, fourth ventricle, choroid plexus, and cisterna magna. And then we change to 2 axial planes, and on the left you see the cranial bones, the choroid plexus filled ventricles, and the midline falx. And then in a parallel plane you see the aqueduct of Sylvius, the thalami, and the cerebral peduncles. Well, then in another parallel plane we see the eyes and the lens, and by turning and angulating the transducer you can display the eyes and the lens in a different sagittal plane. With the oblique coronal plane you can see the nasal bones, orbits, eyes, maxillary processes, maxilla-alveolar ridge, mandible, and the mandibular gap. Here you can clearly see the 4-chamber view. You see tricuspid and mitral valve. You see the ventricular septum. You see the left outflow tract on the right. And then by adding color and radiant, it is easy to visualize the inflow, the left outflow tract, and the 3-vessel trachea view. Well, we can perform first trimester echocardiography either using color or high definition flow. And then by just simply tipping on the touch screen, change to slow flow. So we can depict even tiny vessels like the pulmonary veins and the subclavian arteries. What I use quite often is STIC, spatiotemporal image correlation, because it is so easy and so nice to demonstrate heart anatomy in the first trimester. And you don't have to change the probe. This is done with the transabdominal probe. When using pulsed wave Doppler to examine the flow profile of the ductus venosus and the uterine arteries, you just tip on the right button, and then the right settings for color and pulsed wave Doppler are adjusted automatically. Well, you know radiant combined with color. Now you can add radiant to your B-mode image. And radiant imaging puts a gradient on the 2D image and elevates structures borders for a relief-like appearance and/or 3D effect, like you see on the right picture from Angkor Wat. Therefore, providing better tissue definition and easier, faster interpretation of a higher resolution image. Here you see 4 examples of radiant. On the left, radiant off, and on the right, radiant max. And you can clearly see the image, especially when you look at the ribs and the stomach. A major advantage of the new system is that you choose your preset, you magnify the part you want to examine, and then you can add radiant or ultra HD. Here's another example, harmonic high versus ultra HD, and I think you see the difference, especially when looking at the heart palate and the intracranial structures and the nuchal translucency. Well, what you always have to be aware of is that radiant will change the appearance of your image. So echogenic structures like the heart palate appear thinner, and unechogenic structures like the intracranial translucency and the nuchal translucency appear larger. So this might affect your first trimester screening, your measurement of the nuchal translucency. And this is why I want to show you my audit report from 2022. All examinations were done with the new system, and I always added a radiant. And you can see I examined a total of 601 fetuses, and the median of my NT distribution was 0.12 millimeters above what it should be. So especially when compared to my previous audits, this might be because I used radiant, but in fact it increased my detection rate and I was recertified. But still, the best way to get high quality 3D images is to use a transvaginal probe. But with the new system, it became part of my routine examination to acquire a volume with the transabdominal probe. And it is really nice to demonstrate arms, legs, and the typical fetal position. And for that, you don't have to change your probe, and you can come back later to re-examine structures by using different render modes or the multiplanar mode. So if the fetus is in the right position, it's just one click and the volume is acquired. And then you can use all the post-processing tools like the render mode, like silhouette, and there are some new features like silhouette radius that will change the impression of the picture. Now I want to show you some examples of the impact of high-resolution imaging on the diagnosis of fetal malformations. And we start with arms and hands, and the arms and hands are quite easy to demonstrate in the first trimester because the arms are almost always in the same position and the hands are open, so you can distinguish between the fingers. And here are 3 examples I want to show you. And we start with the first case, and here it was not possible to display the fingers separately. Being highly suspective of syndactyly, and when you look on the right, you see the profile mild micrognathia. And when you look to the fossa posterior, you see that it was not possible to visualize an intracranial translucency. And what you also may notice is that the fetal head appears to be quite big compared to the thorax and to the abdomen. And this becomes obvious when you look at the biometry. In addition, we found an insufficiency of the tricuspid valve, reverse flow of the ductus venosus, and when you look finally at the biochemistry, you see low beta HCG and POP-A. In summary, syndactyly, suspicious fossa posterior, asymmetric intrauterine growth restriction, insufficiency of the tricuspid valve, reverse flow of the ductus venosus, low HCG, and extreme low POP-A being characteristic for triploidy. Next case, this patient was referred because of a history of X-linked hydrocephalus and a genesis of the corpus callosum in 2017. And look at the fingers, and especially look at the thumb. The thumb was permanently adducted. Look on the right picture. The thumb was always in the same position. So again, highly suspicious of X-linked hydrocephalus. And I performed chorionic villus sampling, and the suspected diagnosis was confirmed. And these were the pictures from 2017. Again, look at the thumb on both pictures and both clips, and you see permanently adducted. And then, same story, but a different patient 7 months later, again referred because of a history of X-linked hydrocephalus and a genesis of the corpus callosum in 2016. And again, looking at the thumb, I found the thumb to be permanently adducted. Again, performed chorionic villus sampling, and again confirmed the diagnosis of an L1-CAM mutation. Here are the pictures from 2016, and you can see here in the skeletal mode the fixed thumb. Next example, the patient was referred because of megacystis, but when I examined the fingers, I saw an extreme syndactyly. And this is a genetic overview of syndactyly and polydactyly. And when you look on the right side, you see 4 syndromes combining craniosynostosis and hand malformations. And on the top of the list is Apert syndrome. So I came back using VCIA and skeletal mode, and I saw that the coronal sutures were already quite fused. And the metopic suture was wide open. Not with the typical U sign you see with 22 gestational weeks, but clearly wide open. CVS was performed, and the diagnosis, the suspected diagnosis, Apert syndrome, was confirmed. Well, we've seen 3 hand malformations and 1 with a suspicious fossa posterior. And again here, you see a suspicious fossa posterior. You're not able to visualize the intracranial translucency. And I came back after I did the whole examination and looked again in a mid-sagittal plane, and then I saw a small 3rd line under the nuchal translucency, not being the amniotic sheet. And then when the fetus turned, I saw a small cephalocele. And then I increased the frequency using a transvaginal probe, and then you could clearly see a small myelomeningocele. And this is my last case. Again, suspicious posterior fossa. You see on both pictures here, in the mid-sagittal plane and in the axial plane. In addition, 2 small lateral neck cysts and a tiny human tail. Well, the patient declined invasive testing, but with 16 weeks, persisting lateral neck cysts, and in addition, thoracic cyst, she opted for amniocentesis. And the fetal karyotype was normal, but clinical exome sequencing revealed Noonan syndrome. So the patient presented later in pregnancy with the typical hydrothorax, suspicious cavum septi, and the typical facial appearance with a tall forehead, the small broad nose with depressed root, and the posteriorly angulated low set ears. And what you can demonstrate nicely is the increased distance between the upper edge of the ear and the sutura squamosa. So coming to the end, I think screening, especially in a low-risk population, is all about being attentive at the right moment. And I think the new system will help you definitely. Thank you.